Hey, Assalamu alaikum. Thank you, Dr. Darwish. Good morning, everyone. I would like to thank the organizing committee for inviting me to speak to you today. So I'm going to present the data of the HD21 trial, which is a trial comparing escalated BRECADD versus a new combination BRECADD in patients with advanced stage, previously untreated classical Hodgkin lymphoma. The trial was presented as a late-breaking abstract in the last ICML. So this abstract is an interim analysis of the efficacy endpoint of the HD21, which uses bit-guided escalated BRECADD versus bit-2-guided BRECADD for patients with advanced stage classical Hodgkin lymphoma. So newly diagnosed patient aged 18 to 60 were randomized to receive either 2 cycles of escalated BRECADD versus 2 cycles of BRECADD. Bit-2 staging was done after 2 cycles, and subsequently patients who were bit-negative received 2 additional cycles of either treatment, and patients who were bit-2 positive received subsequently 4 cycles. So a total of 4 cycles in patients who are bit-2 negative, and a total of 6 cycles in patients who are bit-2 positive. At the end of therapy, BIT-CT scan was done, and patients who were bit positive at the end of therapy were referred to receive consolidative radiotherapy. So in this trial, they had 2 co-primary endpoints, and the first endpoint was for superiority for treatment-related morbidity, and this was presented before, and this presentation is about the non-inferiority for efficacy. So a total of 1,500 patients from 9 countries and 233 trial sites were randomized between 2016 and 2022, 749 to the escalated BRECADD and 751 to the BRECADD regimen. An intention to treat analysis, 740 were included in the escalated BRECADD arm and 742 in the BRECADD arm. 9 patients were excluded in each arm because the diagnosis of Hodgkin lymphoma was not confirmed. So you are familiar with the escalated BRECADD. It's actually an intensive regimen with 7 medications. So we use cyclophosphamide, doxorubicin, etoposide, procarbazine, prednisone, vincristine, and bleomycin with G-CSF support. The BRECADD arm, the brentuximab is given on day 1 at a dose of 1.8 milligram per kg, a maximum dose of 180 milligram. Cyclophosphamide, the same dose in the escalated BRECADD. Doxorubicin slightly increased to 40 milligram per meter square. Etoposide dose is reduced in the BRECADD as compared to the escalated BRECADD. Dacarbazine is given instead of procarbazine, with dexamethasone instead of prednisone. And there is no bleomycin, and there is no vincristine. So if you look at the demographics, mostly patients were treated in Europe, mostly in Germany. Slight male predominance, more than 50% in each arm. More than 50% in each arm had an IBS score of less than 3. Median age was 34 years. ECOG performance status was mostly 0. And most of the patients had B symptoms, almost 2/3 in each arm. The staging was 2B in 16%, and 84% had advanced stage 3 and 4. The histology was mostly nodular sclerosis subtype. So if you look at the number of cycles received, 57% in each arm received 4 cycles. So these were the BIT-2 negative patients. And 37% in the BRECADD arm and 38% in the BRECADD arm received 6 cycles, so those patients were BIT-2 positive. And this is actually strikingly high for this intense regimen. So if you compare this data to the echelon 1, for example, more than 80% were BIT2 negative. So the BFS event in intention to treat population at 40 months follow-up, we had 1.9% progression in the BRECADD arm and 0.7% in the BRECADD arm, very low progression rate. And if you look at the total BFS event, 8.4% in the escalated BRECADD versus 5.3% in the BRECADD, much less in the BRECADD arm. And this translated into a 3-year estimated BFS of almost 95% in the BRECADD. And I think this is an extremely high BFS, probably not reported before in advanced stage classical Hodgkin lymphoma. In the BRECADD arm, it was 92%. Median time of observation was 40 months. So the hazard ratio was 0.63, favoring BRECADD, and this established non-inferiority. However, to establish superiority, the confidence interval had to cross the midline, and actually the confidence interval was 1.07 to 0.37. So the superiority could not be established, and they are waiting for the final analysis to probably suggest that this regimen is superior to escalated BRECADD. The overall survival was exactly similar, 98.5% in each arm at a median follow-up of 40 months. There were more treatment-related mortality in the BRECADD arm, 3 mortalities versus 0 in the BRECADD. So in conclusion, there is a relevant reduction in early BFS event in the BRECADD, which resulted in a 1-year BFS of 97.5% and 3 years BFS of 94.9%, almost 95%. So this interim analysis fully establishes non-inferiority of BRECADD compared to escalated BRECADD. As I said, the hazard ratio is 0.63. So these data suggest that BIT-guided therapy with BRECADD is probably the most effective currently available therapy for advanced stage classical Hodgkin lymphoma, and this set a new benchmark for the primary cure rate in advanced stage classical Hodgkin lymphoma. And within the German Hodgkin lymphoma study group, the BRECADD defines the new standard of care for treatment of a patient with newly diagnosed advanced stage classical Hodgkin lymphoma. By this, I conclude. Thank you very much.